Good afternoon, everyone. My name is Michelle McLeod, and I will be moderating today's webinar. Thank you all for joining us today. Before we get started, on behalf of the Athletic Trainers Osteoarthritis Consortium, we would like to recognize our founding sponsor, Sports Medicine Research. Remember, some opportunities there available for you to get those, including a few evidence-based practice CEUs. I'd now like to introduce you all to Dr. Kyle Kosik, who will be presenting his work titled Chronic Ankle Instability and Never-Ending Problems. Dr. Kyle Kosik is a postdoctoral scholar at the University of Kentucky, where he recently graduated from the Rehabilitation Science Doctoral Program. Dr. Kosik's primary research interest is on understanding the origins of neuromuscular dysfunction and biomechanical adaptations following a lower extremity joint injury, with particular emphasis on chronic ankle instability. His current research focuses on quantifying the sensory motor and mechanical alterations that persist across the lifespan in patients with chronic ankle instability. Dr. Kosik, thank you for joining us today.
Thanks, Michelle. Good afternoon, everyone. I just want to first say thank you for tuning in, as well as I'd like to say thank you for the ATOAC for inviting me to talk to you today about an area of research that I am really excited about and have been working on the last couple of years here at UK. As Michelle alluded to, the title of my presentation today is Chronic Ankle Instability, a Never-Ending Problem. And I gave this talk this title because I hope to start a discussion today, or to start to make people who are interested about the ankle or just lower extremity injury in general, about how CAI might not just be a younger adult problem, and rather it might be also an older adult problem as well. Additionally, with this talk, I hope to demonstrate the need for intervening early on when we're working with our high school or college athletes or even patients in the clinic, to prevent any of the long-term complications that I'll be discussing or presenting here today. So just before I get started, I just want to acknowledge some people who have been very influential in some of the work that I'll be presenting today, as well as discussing. They've been along with me for this entire trip, and I can't thank them enough for all their help. So there are a couple of goals that I have today for this talk, and the first one is I hope to describe to you the compelling need for examining the effects of CAI across different age categories. Secondly, by showing you some data today, I hope to illustrate the potential for CAI to result in lifelong self-reported limitations as well as physical impairments. And then at the end, I hope to talk to you about how we're going to move our direction in the future by some of what this data is showing us today. So I think it's pretty well established among both clinicians and researchers that ankle sprains are an extremely common lower extremity injury, if not the most common, among young physically active adults. We know that approximately 40% of all injuries reported among U.S. high school athletics is a lateral ankle sprain. And this trend continues into collegiate athletics, where we see somewhere between 7 to 15% of all injuries reported are an ankle sprain. And we also see a large number of patients treated every year in the emergency room, with the highest incidence rate coming between the ages of 15 and 19 years of age. But we often get this statement right here after someone sprains their ankle, whether that's an athlete, a patient, a coach, a parent, right? But it's just an ankle sprain. They're going to be okay. They'll be back to work tomorrow, or they'll be back to physical activity or playing tomorrow. And while they might be, but what we actually see is that 6 to 18 months post-injury, that 72% of individuals still report having residual symptoms for when they initially sprained their ankle. And even at 2 years post-injury, this continues, with 74% still reporting residual symptoms. And even at 7 years post-injury, we can see that at least 1 out of 3 people will report having continued pain, swelling, or a second ankle sprain. And so we use the term chronic ankle instability as this umbrella term to help describe the clinical symptoms of perceived instability, the recurrent ankle sprains, as well as the repeated episodes of giving way often seen following an acute lateral ankle sprain. So the International Ankle Consortium has recently put out a consensus statement in the British Journal of Sports Medicine, and in that consensus statement, the authors demonstrate how an ankle sprain is a healthcare burden by highlighting some of the literature related to the prevalence of ankle sprains, the financial burden that's often associated with ankle sprains, whether that's the direct or indirect costs, as well as how health-related quality of life and physical activity levels might be impacted after someone acutely sprains their ankle, as well as the risk of joint health degeneration. Now, I don't want to go into too much depth into each one of those categories today, but what I do want to do is just share with you some of the important literature in case you're not very familiar with it. So what we know is that college student athletes right now already report being less physically active compared to their age-matched healthy counterpart. We also know that younger adults with CAI are already reporting having a lower health-related quality of life, and that can be seen using both global and region-specific instruments. And we also see that those with CAI are more likely to have a higher BMI compared to those with a healthy weight. And lastly, we also see that they're at increased risk of developing ankle PTOA. And I think given the forum that we're in this afternoon, I think it's important that we discuss this last bullet point here just a little bit to get a better understanding of the prevalence and the etiology of this disease. So what I don't want to tell you is that the ankle osteoarthritis is the most common joint in the body that develops ankle osteoarthritis or osteoarthritis. In fact, some epidemiological reports would suggest that less than 5%, and I think there's some out there that would even argue that less than 1% of the U.S. general population actually has symptomatic end-stage ankle osteoarthritis. But when we dive into that number just a little bit, what we see is that compared to primary and secondary osteoarthritis, that post-traumatic osteoarthritis makes up approximately 78% of all end-stage symptomatic ankle OA cases. And when we dive into that number a little bit more, what we see is that ankle fractures are the most common form or etiology of PTOA, but what we see is that a combination of lateral ankle sprains account for approximately 30% of all end-stage symptomatic PTOA reports. And so we're not exactly sure why people actually develop PTOA after they sprain their ankle. What we assume that is that some combination of the sensory, motor, and mechanical impairments that are often seen in younger adults with CAI, specifically decreases in static and dynamic balance, a loss in lower extremity strength, changes within gait mechanics, whether that's at the ankle, the knee, the hip, or even just spatial temporal mechanics, and lastly, changes within the spinal reflex excitability. Whereas on the flip side, some mechanical impairments that we often see associated with CAI, decreased weight, dorsiflexion range of motion, and that can be seen using both the weight-bearing lunge test and measures of open kinetic chain dorsiflexion. So when we go back to the initial graph that I just showed you and we look at what age are people with symptomatic end-stage ankle PTOA developing this disease, what we see is that it's somewhere around the 4th or 5th decade of life in those who have actually a history of a lateral ankle sprain. And this is part of the reason why we're not exactly sure why or how people actually develop PTOA after they sprain their ankle, because when we look at all of the sensory motor and the mechanical impairments that are associated with CAI, what we see is that all of our literature or understanding of this pathology is all based on younger adults less than 35 years old. And we have no idea how long these impairments last for. We're not exactly sure which one of these contribute the most. And so this is a major issue at the moment for this body of literature. So there is some reason to believe that the symptoms associated with CAI do persist past the age of 35. So a survey of over 750 middle-aged adults found that 1 out of 5 people actually reported having a chronic musculoskeletal ankle disorder, with 42% of those directly associating that being caused by an ankle sprain. In a more recent survey of over 1,800 middle-aged adults with and without a history of an ankle sprain, found that those with a history of an ankle sprain reported having a lower physical health-related quality of life compared to controls. as well as increasing age and the number of ankle sprains negatively impacted the physical quality of life. And there's also reason to believe or suspect that the sensory motor and mechanical impairments that are associated with adults less than 35 years old also persist past the age of 35, because when we look at otherwise healthy adults, so just advanced age, we know that age brings reductions in sensory motor function. It brings along mechanical restrictions, specifically when we look at dorsiflexion range of motion. And we also know that with aging, health-related quality of life also decreases. Furthermore, we know that these reductions in the sensory motor mechanical measures also contribute to the health-related quality of life in older adults. So what we're starting to see here are potentially some parallels in the deficiencies that are associated both with CAI and otherwise healthy older adults, such as health-related quality of life, sensory motor function, as well as mechanical restrictions. And perhaps there might be some interaction going on between CAI and aging with these parallel deficiencies that might help explain the two recent surveys that I just highlighted, as well that might help explain why some people actually develop ankle PTOA after they sprain their ankle. So with that being said, what I want to do today is share with you some of the work that I've been working on the last couple of years here at UK. So we've been performing a cross-sectional case control study at the moment where we've enrolled younger adults, middle-aged adults, and older adults, and you can see the respective age categories that are listed below each one of them. And then what we did was we subclassified them into two groups, whether that was with CAI or the healthy control group. And then you can see the number of participants that we have in each of the subsequent categories. And all the data that I'll be presenting to you or talking to you about today is based off of this design as well as the number of participants. So we've been collecting several different outcome measurements for this study related to health-related quality of life. So we've looked at some region-specific and global measurements. We've also looked at several different impairments that are often associated with CAI. And then we've also collected a couple questionnaires that are used to look at symptoms related to both the ankle and knee osteoarthritis. I don't want this presentation today to be bogged down by a lot of data, and I don't want it to get monotonous. So what I'm only going to do today is I'll present some of the significant findings that we have so far. But what I wanted to do is I wanted to list all of the outcome measurements that we have included so far in case you had any questions. And if you do, please don't hesitate to ask at the end of the presentation, because I'll be happy to share with you the results of those as well. So for the study that I'm talking about right now, we've utilized the recommendation by the International Ankle Consortium for identifying participants with CAI. So if you're not familiar with that, they had to report having at least one significant lateral ankle sprain, report having at least 2 or more feelings of giving way at the ankle in the past 6 months, and then some form of self-reported ankle dysfunction rated by one of these 3 combinations of these questionnaires at the bottom left. But the problem with this recommendation at the moment is that all of these recommendations are based on younger adults less than 35 years of age. So at times it was hard to apply this inclusion criteria to the current study. So what we had to do was modify our inclusion criteria a little bit. This table represents our inclusion criteria that we'll be looking at today. On the left-hand side, you can see our qualifiers, so the number of lateral ankle sprains, the number of repeat episodes of giving way, as well as our 3 self-reported questionnaires. For the younger adults with CAI, we did decide to keep the inclusion criteria same based off the recommendations of the IAS. But what we actually did is we had to modify it for the middle and older age adults, where those with CAI had to report having at least 2 or more lateral ankle sprains before the age of 35, and at least 2 or more episodes of giving way in the previous 12 months. But you can also see on the bottom that we decided to keep our the cutoff values for our questionnaires the same for both of these groups as well. So just to look at the anthropometrics really quick, on the left you can see we have our age, height, weight, and BMI. We had no significant main effect for age or injury or any significant interaction. But we did have a main effect for age, which does further confirm some of our inclusion criteria related to our age categories. So to start looking at some of this data, we'll first focus on just the health-related quality of life outcome measurements. So just briefly here, we utilize the Foot and Ankle Disability Index as a region-specific instrument. And if you're not familiar with that instrument, it's broken down into two subscales, the ADL and the FADI Sport, with higher scores on both of these representing no self-reported functional limitations. To look at our global health-related quality of life, we actually use the PROMIS 43 adult profile. And this questionnaire is just a collection of 7 different short forms that have 6 items in each one that assess physical function, the satisfaction with social roles and activities, anxiety, depression, fatigue, sleep disturbance, as well as pain interference. So when we looked at our data, this is the region-specific outcomes first. So on the bottom of the graph, you can see that we have our 2 subscales, our FADI ADL and our FADI Sport. We then have it broken down into our 3 age categories, our younger, our middle, and older age categories, with the blue bars representing those with CAI and the gray bars representing the healthy control group. And on the left-hand side of this graph, you can see our percentage, where 100% equates to no self-reported functional limitations. So when we looked at the data, what we actually found was a main effect for injury, where those with CAI actually had lower values compared to the healthy control group, regardless of what their age was. We also found a main effect for injury for the FADI Sport, where again the CAI participants still had a lower score compared to the healthy control group. Then when we switched over and we looked at our global health-related quality of life, again, we utilized the PROMIS 43, and I know that this table gets a little busy, but on the left-hand side, you can see all of our 7 short forms that we have. And then at the top of this table, you can see our 3 age categories, and then further broken down into those with CAI and the healthy control group. And just to draw your attention to the significant findings that I want to talk about today, we found a main effect for injury for the physical function as well as the pain interference short forms. So when we looked further into that data, what we actually found on the left-hand side of physical function was that the CAI participants, regardless of what their age was, they had lower values compared to the healthy control group, which suggests that they report having greater physical functional limitations during their day-to-day activities compared to the healthy control group. Whereas on the flip side, when we looked at the pain interference short form, what we saw was that those with CAI, regardless of what their age was, they had higher values compared to the healthy control group, which indicates to us that they are reporting having greater bodily pain during their day-to-day activities compared to the healthy control group overall. So let's move over to the impairments now. When we looked at the impairments, our significant findings were focused on lower extremity strength as well as dorsiflexion range of motion. So I'm just going to briefly highlight some of the results in those 2 categories. So we looked at isometric peak torque both at the ankle, knee, and hip, and in each one of these pictures you can see the participant positioning for them. We looked at plantar flexion and we'll look at plantar flexion and dorsiflexion first, and then we'll look at the results for our knee extension, and then we'll finish looking at the results for our hip abduction and our hip extension. On the bottom of the screen, you can see how we calculated our peak isometric torque. So we took our average peak force and we multiplied that by our moment arm and divided it by each participant's body weight to arrive at our peak isometric torque. So again, same looking graphs. So on the bottom, we have our dorsiflexion and plantar flexion broken down into our 3 age categories again, our young, middle, and old, with the blue bars still representing the CAI group and the gray bars representing the healthy control group. Overall, we did find a main effect for both positions, with our post hoc analysis just indicating that those older participants, regardless of what their injury classification was, produced less strength compared to the younger group. But what's more important for today's talk is the main effect for injuries that we found for both dorsiflexion and plantar flexion. So in both cases, what we found was that those with CAI, regardless of what their age was, produced less isometric peak torque compared to the healthy control group. Switching over to look at our knee extension, we did not find any significant main effect for injury or age. Likewise, when we looked at the hip abduction, we again found no significant main effect for injury or age. But what we did find for hip extension, which was interesting, again, was the main effect for age, with the post-hoc analysis telling us that the older participants, regardless of what injury classification they were put into, produced less isometric peak torque. But more importantly, what we also found was that the CAI group also produced less isometric peak torque compared to the healthy control group, independent of their age. So when we looked at dorsiflexion range of motion, we utilized the weight-bearing lunge test first. So we utilized the knee to wall principle, where our dependent variable was just maximum distance reached. Therefore, lower values on this test actually represent decreases in dorsiflexion range of motion. We also looked at dorsiflexion range of motion in an open kinetic chain format. So we asked participants, where we placed participants in a hook line seated position with their hips and knees at 90 and then the ankle at neutral, and then they were just instructed to maximally dorsiflex for us. When we looked at the results, on the left-hand side on the bottom, you can see our open kinetic chain dorsiflexion range of motion, and on the right-hand side represents our weight-bearing lunge test scores. It's then again further broken down into our young, middle, old, with the blue bars representing those CAI again, and the grays representing the healthy control group. We didn't find a significant main effect for injury or age for open kinetic chain measurements. But what's interesting is that when we looked at the weight-bearing lunge test, we did find a main effect for injury where, regardless of what their age was, those with CAI had decreased dorsiflexion range of motion compared to the healthy control group. Now, switching over to some of the questionnaires that we use to look at OA symptoms at both the ankle and the knee, we first looked at the ankle using the ankle osteoarthritis scale. And if you're not very familiar with this questionnaire, it's just a series of 18 visual analog scales, and it's broken down into two subscales, the pain and the disability subscale. And then we can also derive a composite score, which takes into consideration both subscales. Higher scores on this are going to equate to greater symptoms related to ankle OA. So in this table, again, on the left-hand side, you can see our two subscales, the pain and the disability, and then the composite score. And to highlight the significant findings, we found a significant or a main effect for injury where those with CAI, regardless of what their age was, self-reported having greater symptoms that were related to ankle osteoarthritis compared to the healthy control group. Then when we looked at the knee, we utilized the knee injury and osteoarthritis outcome score, so the KOOS. The KOOS is just made up of 5 different subscales again, with higher scores equating to no symptoms and 0 indicating extreme symptoms. And to zero in on the findings here, on the left-hand side, again, we have our 5 subscales, but we found a main effect for each single subscale for injury, where regardless of what their age was, those with CAI self-reported having greater symptoms related to knee osteoarthritis compared to the healthy control group. Now, what I don't want you to run away from this presentation is saying that Kyle's trying to tell me that an acute lateral ankle sprain causes knee osteoarthritis, because that's definitely not what I want to tell you, and that's definitely not what I'm telling you. But what I do think is when you take some of this preliminary data that I'm showing you today in consideration with a recent paper that was featured in the osteoarthritis special in the Journal of Athletic Training last month by Tricia Hubbard, who found that after being induced with an acute lateral ankle sprain in mice, that there was actually a reduce in the knee joint space. So perhaps this might be something that we need to look to in the future when we're looking at our patients or when we're looking into the effects of CAI. So just to kind of recap, I know that was a lot of data and it could have been bogged down, but I just want to recap kind of what we saw in our main findings. So when we looked at all of our sensory, motor, and mechanical impairments that are often associated with CAI in younger adults, as well as health-related quality of life outcome instruments, what we ultimately found was that regardless of what their age was, those with CAI reported having worse region-specific and global health-related quality of life, as well as having decreases in dorsiflexion, plantar flexion, and hip extension peak torque, as well as a loss in dorsiflexion range of motion based on the weight-bearing lunge test. And lastly, we also found that that those with CAI also reported having greater symptoms related to both the ankle and the knee OA. And really that these findings are kind of what's getting us to start thinking of what we're going to do in the future, and this is something that's driving us where we're heading to next, is this last bullet point here. So at the moment, we're working with some of our colleagues down at UNC Chapel Hill, where we are actually assessing the integrity of the articular cartilage in the talocrural joint using T1 row MRI analysis technique. I don't have any data to share with you at the moment because we're still in the process of actually physically collecting the data and analyzing the data. But what I wanted to share with you today is just a glimpse of our study design and what we hope to do with some of the data once the study is finished. So we're still keeping our same study design where we're going to still enroll our younger and middle age and older age adults, and then we're going to keep the same age categories. And then we're again just breaking them down into two groups, the CAI group and the healthy control group. And you can see at the moment the number of participants that we've actually physically have enrolled so far for the study. So with some of this data, what we're hoping to do is we're hoping to look at, into each age category, which of these health-related quality of life instruments or the impairments help contribute to the development of ankle PTOA. And by doing this, what we hope is that we can start to answer the problem that I proposed at the very beginning of this talk was what combination or what factors associated with CAI are actually going into the development of ankle PTOA. So hopefully we can start answering some of these questions and come up with some innovative and novel techniques to help prevent these consequences from ever happening. And the last area that we're really focused on and that we're moving towards is we're actually trying to try to understand why people often have decreased static postural control after they sprain their ankle. And why this is important to us is because we know in a recent paper that looked at health-related quality of life outcome instruments that static postural control, along with a couple of different other outcome measurements, significantly contribute to the health-related quality of life in those with CAI. So what we're doing is we know that postural control is dependent on the sensory input coming from the periphery and as well as the fidelity and the integration of that sensory input. So we're actually going to look at the cerebellar peduncles as well as the cortical spinal tract white matter using diffusion tensor imaging or DTI. And at the moment, we have collected some data, and one of our former colleagues, Dr. Terada, has actually spearheaded a lot of this work. And at the moment, when we're looking at the data, we see a moderate correlation between static postural control and the cortical spinal tract, the integrity of that. So hopefully, if this correlation does hold, then hopefully we can start to intervene using some form of balance training, and we can give some credence to what some of the work has been coming out, focus on balance training. So before I wrap up here today, I just want to give a quick plug to the to next month. So next month we're having the 7th International Ankle Consortium Symposium at Chapel Hill. If you're interested at all in ankles or CAI, I highly recommend attending. It's going to be a great conference, and we're looking forward to it. Thank you.
Kyle, great job. At this point, I would... All right, I'll start with a question. So this is kind of a take-home point, I guess. I'm wondering from a clinical standpoint, Kyle, you mentioned that there's a lot of different tools that are used out there, whether it's, you mentioned the FADI that you guys used and the SAM. which of those tools would you recommend a clinician who's wanting to start to maybe try to capture some of this dysfunction? Is one more useful than the other? Does it matter? But how can we start using some of this information from a clinical standpoint?
Yeah, that's a great question. So I think there's some really good evidence out there to recommend the use of the FAME. The difference really between the FAME and the FADI is the FADI has a couple of extra questions related to pain within the ankle. And so because we were kind of going down a different avenue and we were trying to look at CAI in both the middle and older adults, we decided to enroll or use the FADI because we wanted to capture the prevalence or maybe the impact of pain in both of these older age categories. So that was the real reason why we decided to use the FADI. But from a clinical standpoint, I think either one of those questionnaires is effective. The FAME does have the advantage of it being shorter, and I also think there's also some work coming out by Dr. Hook, who has actually looked at creating a shorter form of the FAME, so the quick FAME. So as a clinician, if you just want to capture some of this data really quickly, use it as a guide or a tool to look at the progression of your rehab, or if you're impacting how someone is feeling, I think the FAME is a good tool.
Great, thank you. Any other questions?
Hey Kyle, it's Jennifer Howard here. I apologize, I had some user technical challenges at the beginning. I missed part of your first part, but out of curiosity, what were your, beyond just the ankle symptoms for the CAI groups, what were your inclusion and exclusion criteria? Because those KOOS scores, particularly for your older group, look above age norms. So I was just curious if you had activity or previous injury, or what were the requirements for the healthy group?
Yeah, so we didn't. So we excluded anyone who self-reported having any type of, first of all, surgery. That was definitely an exclusion criteria. And then anyone that had self-reported having any type of major knee or just in general lower extremity injury in the previous 6 months. We do have some of that data, or we do have that data available to us. Typically, in the middle and older age adults, we only came across 1 or 2 people that actually self-reported having a major lower extremity injury in the past, and it was typically when they were a lot younger is when they had it. So we didn't exclude anyone based off of whether they had a lower KOOS score or anything like that. Does that answer?
Yeah, if they didn't have a history of injury but had been diagnosed as NEOA, were they eligible?
Yeah, so we only had 1 person that came across that actually was diagnosed with NEOA, and they were in the older age group, and we decided to enroll them anyways. But if we ever decide that, we're going to covariate hopefully for some of that, that as well, because that's definitely a major factor when we're looking at the KOOS scores, whether they do actually have NEOA. The reason why we did include them was because they did have an ankle sprain history, and if we want to start looking at some of these potential associations, we decided to include them anyway. So that's definitely something that should be taken with caution and into consideration when we're looking at this data and considering it.
Oh, they were in your CAI group. I meant in your healthy group.
No, so sorry, no one in the healthy group was diagnosed with any type of OA.
Okay. And that just was by luck of the draw?
Yeah. Yeah, I mean, when you looked at my numbers, we didn't enroll a bunch of people. They're really hard to find true healthy people that don't have any type of chronic disease who are 65 and older. So it's really hard to find those, but that's part of the reason why we have a low sample at the moment. But that's why I feel pretty confident about some of this data, is because we do our best at trying to exclude anyone that has, even a stroke, heart attack, they're not included, stuff like that.
Yeah, that's what I wondered. If it's not just ankle healthy, you want the healthy of the healthiest.
Right, exactly. So we're not looking for, we're not going to the, the local nursing home and trying to enroll those people. We're trying to find.
Hopefully at 60, they're not in a nursing home.
No, you're right, but you never know.
Yeah. Thanks, Kyle. Great stuff.
Yep.
Any other questions? Kyle, I know that you're a fan of 2-part questions, so I was sitting here trying to come up with one, and I think I have one. So at the beginning of your talk, you were mentioning the risk of PTOA, and we kind of set that up as the focus for this talk today. And honestly, I was a little bit surprised at the discrepancy between the prevalence of knee OA and ankle OA, given how many people suffer ankle sprains annually. So the first part of my question is, why do you think that there is such a large discrepancy between those two joints and the onset of PTOA? And also, part two of this question is, you know, we know that some of these changes in the knee happen fairly soon after the insult of injury. Do we know anything about how quickly these changes are occurring in the ankle?
Yeah, that's a good question. So to answer the first part, I think when you have to take it, there's two reasons in my mind. The first, when you compare the ankle and the knee, you have to realize that the two different types of joints that you're looking at. So the ankle is a little bit more of a stable joint because it's a close packed or it's a more stable joint because of both the medial and lateral malleolus, whereas the knee, you get a lot of shear forces and a lot of compression and rotation at the knee, whereas you probably don't get as much at the ankle. And then secondly, when you look at just the cartilage makeup, we know that the cartilage in the ankle is a lot more resilient to high impacts and the rate of load. So that's why I think where you don't see as much of ankle PTOA versus what we see at the knee. To answer the second question, so I think it was related to the age. Is that correct?
I think you really kind of answered it in the first answer as well. It was really more just about onset of PTOA in the ankle. You know, we know that it does occur fairly soon after knee injury. So just kind of you answered it in that question.
I mean, I definitely think though when you look at that slide that I presented where it's happening though in people with ankle PTOA somewhere around the 4th or 5th decade of life. I think that's still significantly, I think that's still pretty early, especially when you consider some of the ankle replacement surgeries out there for end-stage symptomatic PTOA or osteoarthritis. They're probably not the most effective. They don't last as long as what we hope that they would, and we still see changes going throughout the lower extremity once patients actually go in and get an ankle replacement. So I think it's still pretty alarming that it's happening somewhat sooner than what we actually hoped that they would actually be developing OA.
Definitely. Brian, you have your hand up?
Yeah, can you hear me?
Yes.
Great job, Kyle. I really enjoyed that presentation. Hey, I was interested in your thoughts on, you know, the association between CAI and people having symptoms of knee osteoarthritis. Were you able to determine, one, if that was coming from the ipsilateral limb or the contralateral? And then my other question is there any data to suggest that after or when people have CAI that they offload their weight to their opposite limb? Or do they typically have symmetrical, you know, loads when they're doing things like walking or running?
Yeah, that's a good, so from a loading standpoint, so when, if you look at like ground reaction force data, there's not a lot out there related to the ankle sprain or the CAI in general. So I don't think we know whether that they have bilateral differences from a loading perspective, but what I think we do know is that there are some bilateral deficits and impairments such as balance, which might contribute to some of that. A lot of the knee OA stuff that we collected, it was all based off of the involved limb, so we didn't collect any data on the uninvolved limbs. So all of the knee OA, the Kosik scores, that was all based on the involved limb, so we didn't actually collect bilateral Kosik scores. Not sure if that answers your question.
Oh, yeah, thank you. So nobody's really looked at gait and ground reaction force in people with CAI?
So they have, but I don't know if we can definitively say that there's a bilateral difference that's actually causing the Kosik scores. I think what might be causing the Kosik scores in our study is more of the weakness at the hip that we found, as well as just some of the aberrant movement patterns that we know as people who are walking both at the ankle, knee, and hip. So I don't know if we can definitively say that they're offloading onto the opposite side or what's causing that, and that's my point. But people have looked at ground reaction forces in those CAI and found that they actually have different ground reaction forces when they're running. So we know that they have an increase in the rate of ground reaction force as well as the peak.
On the injured limb?
Yes.
Interesting.
So we have that data. So at the moment, we do have the data to look at the ground reaction forces as participants are walking on both limbs. So that's something that we're going to look at further this coming year as well. So we have that data already. We just need to pull it off and look at it.
Great. Any other questions? All right. Well, Kyle, thank you very much for sharing your research with us today. If you missed part of the presentation, this will be posted on the ATOAC YouTube page in the near future. And if you are attending and are not a member of the ATOAC and are interested in participating or getting involved, you can check out the ATOAC webpage. So thank you, everyone, for attending this afternoon.